Very good morning. Since all of us are getting better and better at performing cataract surgery by attending such lovely conferences, now I think time has come that in challenging situations, patients presenting with different comorbidities, not just cataract alone, but with other pathologies like cornea, retina, so on and so forth. It's time that we learn to work with our colleagues in different subspecialties. And this course is basically aimed and designed to cater to that how do we approach a patient who has different other comorbidities along with the primary cataract. So our first talk, I'd like to invite Dr. Vanda Nath. She's from Raghudipai Hospital, Ahmedabad. I'm Dr. SHAIL VASAVADA from Raghudipai Hospital, Ahmedabad. And Dr. Vanda Nath will be talking to us about how to approach from the refractive point of view in a patient having pterygium along with cataract.
Good morning, everyone, and thank you, Dr. Shail, for including me in this course with such an august faculty. And thank you, the people in the audience, for being here so early. So all of us have always and quite often faced this situation where we are going to operate a cataract, but there is also the comorbid condition of a very irritating but a very common problem, that of pterygium. So how do we know whether this pterygium is going to impact our cataract outcomes in the forms of our biometry and the choice of IOL? And if so, what do we do about it? The most important thing would be the preoperative evaluation, where we are not only going to evaluate the cataract and perform a perfect biometry to get a minimal or negligible residual refractive error and the choice of IOL, but we need to evaluate the pterygium as well in terms of its site, size, and the grade of pterygium. So we go back to our residency days, and the history is the most important part. How long this patient, is the patient first of all aware that he has a pterygium? How long the pterygium has been in the eye? Did the patient notice whether it's progressing? What is the patient's visual requirement? What are the visual tasks that he needs to perform during the day? The status of the fellow eye is very important. What has been done in the fellow eye or not yet done? And of course, we cannot undermine the importance of counseling, good counseling regarding the patient's eye and what we are going to do. So there are three surgical options. One, first we do only the cataract surgery, leave the pterygium as it is. Operate it later if it progresses. Do only the pterygium first and at a later stage do the cataract surgery. Or third is combine the cataract and pterygium surgery. We'll take the first option and we are going to discuss, these are our own cases that we have performed and counseled for these, where we have done only the cataract surgery. This is a 76-year-old lady with hardly any visual activities and demands. She has and the left eye, she has had a toric IOL a month ago. And while we may want to immediately jump onto this lovely grade 3 nuclear sclerosis, there is a pterygium lurking there, where we can see it's a atrophic, thin, small pterygium, which is not so-called impacting her visual field at all. Ideally, while measuring the keratometry, which is perhaps the most important part of the biometry, more than one keratometer, at least 2 keratometry readings which are repeatable and reliable should be done. Because we know that all pterygia induce some kind of astigmatism. So we want to know the magnitude and the axis of the pterygium. We want to know the regularity. So in addition to the 2 keratometers, we should do a topography as well, if not a Scheimpflug imaging. So this is the kind of regularity that we want in a cornea, in which we are going to put or plan a toric IOL if there is significant astigmatism. The typical bow tie pattern that you can see here. So in this case, the keratometry showed a minimum astigmatism, but it was against the rule. So we expect a 0.5 to at least a 0.75 diopter of astigmatism. And this pterygium, as I said, it not only causes a little irregular astigmatism, but higher order aberrations. This is the aberrometry profile of this patient. And if you can see these higher order aberrations, which is the coma and the trefoil. So be careful of these, and therefore the choice of our IOL would not be any high-end IOLs, the premium IOLs so-called, because all pterygia, these are the studies that show that pterygium and its size have significant influence on higher order aberrations of the eye, especially on the coma and the trefoil. So in this patient, we went ahead with a simple monofocal IOL, and she had a reasonably good vision of 6/9 with a minimal residual astigmatic error. So at least our residual spherical error was taken care of with a good biometry. This is a very challenging case that we had, a 65-year-old male with a left eye cataract, absolutely does not want a pterygium surgery because he's a high-flying businessman and needs to travel a lot. Very, very active gentleman. And we noted that his mesopic pupil was only 2.5 mm and maximum pupillary dilatation was 6 mm. To make it worse, the other eye was operated elsewhere, and if you can see the central rings, there's a multifocal IOL, there's an iris chaffing that you can see, and if you notice here that there is a big pterygium here, and he has a full thickness macular hole with a very compromised visual acuity. So this made our task even more difficult. We did a Scheimpflug imaging with a good anterior and posterior elevation curve. And we did a topography to see if, because this pterygium was inducing at least 5 diopters of astigmatism, what is the next best thing we can do for this patient? Can we reduce his dependency on glasses in any way? So we were trying to see if we could correct this astigmatism in some way, and we did the topography. And if you notice this dotted line, I'm showing the arrow. This dotted line is his pupil, and within the pupil there is a reasonable bow tie appearance, so reasonably regular astigmatism that you can say, plus his pupil was not fully dilated. So probably we could get away with doing a toric IOL, and we did optical biometry and used the Barrett toric calculator, which is incorporated in the LensStar, and we put a toric IOL T9, and his best corrected visual acuity with a minimal residual refractive error, and patient was very, very happy, even with that large pterygium in his eye. Option 2 is a stage surgery. So where the option 1 was where we left the pterygium alone in 2 situations. Now these 2 situations are where we do the stage surgery, where we do the pterygium surgery first, even though the patient had come to us for a cataract surgery. This is a lady with a fleshy pterygium, and she's showing a very high astigmatism. If you see the steep and the flat axis, which is circled in red, you will see the high astigmatism, almost 5 to 6 to 7 diopters of astigmatism, along with the higher order aberrations. After the pterygium surgery with a conjunctival autograph, we not only lowered the astigmatism, we get rid of the higher order aberrations, and now she has a regular astigmatism. And we waited after the pterygium surgery for 3 months, did a toric IOL, and the patient was counseled about post-op surface symptoms, lubricating drops given for a long time, and unaided 6/9, a very happy patient. And this is just to show the surgery of the conjunctival autograft. I'll skip this since this is the autograph we use with the tissue glue, and I'll go to the next one. This was a recurred pterygium. She had this huge pterygium since 15 years. So I expect a lot of scarring in this eye, and only when her cataract was nearly mature did she come to us, and she insisted on getting both the surgeries done together. And we insisted that we would not do it together. With a BCVA of CF1 meter, this is the post-op picture of the recent 1-week post-op where we did a big conjunctival autograph. And you can see the scarring on the cornea. Now this cornea is going to take at least 6 months to heal. So don't go ahead with a cataract. If you want to give the best visual outcome to this patient, do not try to undergo a cataract surgery immediately or together along with the same. But if you notice, she was so happy with her best corrected of 6/18 after the pterygium was removed. So this was another very rewarding thing for us. And we waited for 6 months and then operated her. But because of the scarring, we would not advise any IOL other than the spherical IOL, a non-aspheric IOL. So we put SA6080 and she was very happy with that. We kept a close watch for follow-up and kept assessing the cataract. And these are the studies which show that pterygium excision can significantly reduce the pterygium-induced higher order aberrations, and topographic changes take about 6 months to a year to stabilize. If pterygia are small, do not impact and do not impact K readings, they can be left alone. The option 3 is a combined cataract and pterygium surgery. This we do not advocate as much as possible because you will not be able to give the best visual outcome to this patient. This is a patient with a double-headed pterygium, and she was always uncomfortable with her glasses. These are the higher order aberrations and the high astigmatism. This is the quality of her vision. The simulated E-chart shows you the quality of her vision. And such poor vision she had. We did the Scheimpflug, almost a 6 diopter of astigmatism. And if you see, this is showing, if you go ahead with this without removing the pterygia, it's showing you a 24 diopter T8. Okay. This is the surgery we did, and 2 weeks, this is post-op. All the aberrations have gone, her astigmatism is gone, the quality of vision has improved. And this is an example to show you that if we had done this simultaneously, if you had done the pterygium and the cataract simultaneously, you would have gone way off in your IOL power calculation. And this is the last case where again the same thing, and this is the surgery where we did 2 conjunctival autographs, 1 week post-op, the improvement, and this is post-op 10 days. So ocular wavefront aberrations constitute the most important part of the optical quality of the eye, and pterygia lead to deterioration of the quality. Treat each patient, each eye as with equal evaluation, with a very, very detailed evaluation, so that we can give our patients the best visual outcome. Thank you.
Thank you very much, Dr. Vandana ma'am, for this wonderful array of cases. And I think the important take-home message that I particularly learned was that we need to look at, like in any comorbid eye, we need to look at the severity of each disease. So if we find that the pterygium severity is much more than the cataract itself, then I think it's best idea to treat the pterygium first. And like Dr. Vandana madam showed, that along, not only does it help in improving the ocular surface, improves your cataract surgery outcome as well, and just removing the pterygium itself help to reduce the higher order aberrations significantly to improve the quality of vision. But the first set of cases which she showed are the more practical ones, which we keep facing more often than not. Patient in their mid to late 60s, 70s who have had atrophic pterygiums and are comfortable with that and are not keen for any surgery. These are the eyes we need to evaluate more thoroughly, particularly for IOL power selection. And if you have a regular astigmatism on any form of topography, you can still consider toric IOLs also in such situations, but be careful before choosing that. Thank you very much, ma'am, once again. I would like to now invite Dr. Aditya Sudhalkar, who is a prolific retina surgeon predominantly from Baroda, from Sudhalkar Eye Hospital. And he'll be talking to us of how do we approach a patient in a who has a cataract, but recurrent or past active or old uveitis.
Thank you, and a very good morning to all. Thank you for letting me be a part of this IC SHAIL. And before we start off, just a couple of pointers. Everybody knows that anterior uveitis is often associated with complications such as synechia, which necessitate the use of pupil expanders and so on and so forth. Additionally, all of these patients, regardless of what type of uveitis they have a propensity to develop intense post-op inflammation, necessitating the use of additional immunosuppressive therapy to ensure a good visual outcome. So what I'll be just doing is starting off with a couple of cases to put things in perspective, and then discuss some of the studies or some of our own published literature on this topic. So this was a 57-year-old lady who came to us with decreased vision in the left eye since 1 month and had a similar complaint 1 year ago. So she had been diagnosed to have macular edema elsewhere, and because she was a diabetic, it was presumed that it was diabetic macular edema. So the vision in both eyes was slightly off the mark, but especially in the left eye, where as you can see it was 6, 18 and 10. So the anterior segment in both eyes showed posterior synecdoche, intense cells, flares, and even vitreous cells. So this is the fundus photo of the left eye. And as we see here, I don't know if we have a pointer here, but there are certain areas of not only hard exudates that you see there, but also superiorly, along the superior border of the fovea, you will see choroiditis patches as well. This is just a composite that shows you, the late hyperfluorescence in figure B. And what figure C shows you is obvious macular edema along with subretinal fluid. So we chose, after appropriate discussion, we put her on, intravitreal Ozurdex therapy, and you can see the implant in position here. So that led to near complete resolution of the edema. A year later, she developed cataract, and she was part of our trial on combined cataract surgery and uveitis management. She had an uneventful surgery. Along with, so she received an intravitreal dexamethasone implant at the time of cataract surgery as well. 6 months down the line, she developed edema again. Is it seen here? But so she received a second injection thereafter. The second case is of a patient with a similar history. These are the angiographic sequences of the left eye. You can see obvious edema here. The fundus photo appears dull, and that is because of the cataract. She had a similar picture in the right eye as well. As you can see, both the OCT show obvious cystoid macular edema with subretinal fluid. She underwent cataract surgery with concurrent dexamethasone implant injection. And there was a history of tuberculosis in the family as well. So post-operatively, as you can see, first we chose the left eye. Complete resolution, never had a recurrence since, at least for the first 6 months. On an average, she needs about 1 injection per year per eye. This is the right eye, and then a similar procedure was done in the right eye as well. So this was a trial that was sponsored by Allergan, and wherein we compared the efficacy and safety of concurrent dexamethasone implant, utilization along with cataract surgery. And the other group received cataract surgery with systemic steroids. So coming to the results in the interest of time, as you can see, there was a drastic improvement in vision in both groups. Nothing to choose really between the groups. And that was the aim of the trial, to show non-inferiority of the dexamethasone implant as an alternative to systemic steroids, which, as everybody knows, has their own set of side effects. This is the central macular thickness. And as you can see, initially there was a steep rise and followed by a significant drop in the central macular thickness, again indicating the efficacy of steroids in both groups. Now, just a couple of videos, and because this is an increasingly common procedure, how to inject the dexamethasone implant at the time of cataract surgery. So what is important is that, and I'll just pause the video here if possible, after lens implantation, it is important to inject a viscodispersive in the anterior chamber to ensure that all the ports, that is your the main port as well as the side ports, are effectively blocked. A viscocohesive might give more tensile strength to the eye, but it is easily removed from the eye, and therefore any inadvertent excess pressure can actually cause it to leave the eye and result in more hypotony. So what is important is a viscodispersive. It can be Viscoat or any, from any other company, is injected into eye prior to injecting this implant. The other thing, and if I can just go back for a minute, is that it is generally done 3.5 millimeters from the limbus, and the bevel should be facing downwards. So you will actually see the implant going in without, and then you remove the viscoelastic. Everything else, it just follows as you would for any other cataract surgery. Now, in the second case, or rather the second video, it's more about what not to do, while you're injecting the dexamethasone implant concurrently with cataract surgery. So here we see the viscoelastic is being removed prior to injection. And when the surgeon actually takes up the needle, the direction of the needle should be towards the optic nerve. Here you will see that it is horizontal with the bevel actually facing upwards. So this means you can also see that little nudge that the IOL received. So in this case, what happened is that the implant was injected in the bag and then there was a posterior capsule alert. Now, because the surgeon was highly skilled, he was actually able to do a reverse optic capture. That is, the optic was placed in the sulcus with the haptics in the bag. Fortunately for the patient, he had a very good outcome. There was no problem insofar as the uveitis was concerned and insofar as the cataract surgery was concerned. But this is not everybody's piece of cake, and which is why just the position of the implant or position of the applicator needle is extremely important while injecting. The third option, especially in a country like India, is triamcinolone. But the problem with triamcinolone is its high propensity to cause IOP spikes. So what we generally do is, at our center, we do a conjunctivotomy and a tenotomy. And we actually use a viscocannula to inject triamcinolone exactly in the subtenon space. So this technique has two advantages. One is you avoid inadvertent perforation of the eye because of the use of a needle. Very often we inject. Secondly, many a times the injection actually goes into, or rather the drug goes into the subconjunctival space, thereby not only reducing the efficacy of your injection but also causing IOP spikes. So intravitreal triamcinolone is something that we avoid as far as possible. This is an important option, especially in a country like India, where obviously not everybody can afford the dexamethasone implant. This is yet another trial that we had, or rather a retrospective study that we had done. And what we saw is that we collaborated with international centers to collect about 152 eyes that had received a total of 358 DEXA injections. The mean gain after cataract surgery was 12.1 letters, and 35.5% gained 15 letters or more. So 40% of patients eventually needed cataract surgery at some point in time. Most patients at recruitment were phakic. There was a subset of pseudophakic population, but that was very low. And nearly 28% needed some IOP lowering therapy. That is not something to be alarmed about, simply for the reason that none of the patients needed incisional surgery for glaucoma because of the implant. So just skipping, the position of the implant in the eye is also something that is very important. The closer it is to the pars ciliara, the higher the chances of IOP spikes. And we have managed to publish this, and this is just an illustration. As you can, this patient came back to us with an IOP spike of 38 within 3 days of injection. So overall experience, excellent result at primary therapy. The use of the dexamethasone implant or any steroid drug concurrent with cataract surgery will help us reduce the chances of post-operative inflammation. It gives excellent post-op results. And, as I said, if you are using it in phakic patients, only if you go beyond 2 injections a year does it actually influence cataract progression. So, except for some freakish complications, we have found that the use of steroids concurrently with cataract surgery gives excellent results. So, thank you very much for your attention.
Thank you, Aditya, for that wonderful talk. And it's important to understand that although we do use systemic steroids quite often, they do come with their own systemic side effects, particularly if the patients are relatively elderly. Aditya, just one question before we move to the next presentation is that if, say, the eye is otherwise quiet, uveitis has been stable for 6 months, 8 months, and we are planning a cataract surgery, synechiae are there. Would you still recommend combining it with an intravitreal implant, or you think you would want to wait and then consider in the post-operative?
As a rule, these people will have a higher quantum of post-op inflammation as compared to, say, a routine patient. Okay. So even if we have sometimes seen patients with anterior uveitis. Let's not even talk about posterior uveitis. Anterior uveitis stable for a year or two, and then you do a routine cataract surgery without any prophylaxis. It could be systemic steroids or any drug. They do come back with a membrane. And then, you spend an anxious week thinking that, okay, it should not be endophthalmitis. It is actually the uveitis recurring. But some form of immunosuppressant, it could be more intense or more frequent steroid therapy, topical steroid therapy. It could be a subtenon injection. It could be the dexamethasone implant. But yes, I would definitely recommend some form of immunosuppressive or more intense immunosuppressive therapy in cases which have had uveitis.
Thank you very much.
May I ask a question?
Yeah,
and would you recommend starting oral steroids pre-operatively, and how soon before the surgery, if at all?
If the patient cannot afford an implant, definitely. But now, as I showed, even triamcinolone, which is very cheap, So I think we can forego oral steroids in most cases if we are dealing with a quiescent eye. So unless, of course, you know that you have to operate in a case which has had a very recent recurrence, I would avoid oral steroids entirely.
Thank you so much, Aditya. Moving on to another very, very common disease, particularly from where we come from, Gujarat, diabetes. And all of us will be encountering patients who have cataract and who have diabetes active, along with some or the other form of diabetic retinopathy. So, Dr. Shamal Dwivedi, who is a retina surgeon in Ahmedabad Raghudipai Hospital, will be teaching us how to deal with a patient who has cataract and diabetic eye disease.
Excuse me. Okay, so good morning everyone, and I'll be starting my presentation regarding diabetic and cataract co-management. So as we all know that we are set to become a diabetic capital in the world by 2030, and the prevalence of diabetes is also, diabetic retinopathy is also quite, and it just doubles in the urban population and then what it is in the rural ones. So 53 okay. So it is the duration of the diabetes which is extremely important, as we all know. So after 20 years of diabetes mellitus, 98% of type 1 and 60% of type 2 will have some kind of diabetic retinopathy. And out of those patients who are having diabetic retinopathy, 5% of them will definitely have proliferative diabetic retinopathy. So now we come to the main portion. We are not going much into the theory, that is treating cataract and diabetic macular edema together. So there are two basic approaches. The first approach is to dry out the macula. So when there is a macular edema, we usually want to dry out the macula. We want to inject something. We want to make sure that the macula is completely okay. The patient is free of diabetic macular edema, and then go ahead with the cataract surgery to give optimum results. So this is one of the approach. And the second approach which I'll be discussing today is the combined approach, in which diabetic macular edema is managed and cataract both are managed together. So this is especially important in patients who have very advanced cataract. They have excessive glare, who are not able to drive their vehicle or not able to perform their daily activities, and some comorbid conditions in which the patient cannot come to the clinic again and again. So this becomes very important in such patients. So again, we'll not go to the theory, but what I have understood is we need to make patient aware about the good glycemic control. That is the first and the foremost, because they actually, most of the patients actually does not know what is going on with their eyes. And once they come to know that it is their body problem which is manifesting in the eye, they'll be able to understand their problem better and will be able to cooperate in a good way. So the next important thing is counseling. And I cannot emphasize more that these are the most important parts which has to be taken care of. And the most important in our institute is the OCT. We do OCT in most of the patients, in almost all the patients, except mature cataracts and black cataracts where we cannot capture the images. So OCT is the first and the foremost thing we should not forget in any of the eyes. And the second thing is a vitreoretinal consultation to see if any what to expect. I mean, sometimes there is no diabetic macular edema, but there are some microaneurysms, or there are a very subtle DME which we are not sometimes able to even pick up. So a vitreoretinal consultation is very, very important in patients with diabetes. So I again won't go into the details. So the diabetic macular edema is the accumulation of the fluid in the macula. So I will be not going into it. So let us see what are the options for the DME management. So as we all know that there are injections, laser and surgical treatments available for diabetic macular edema. The anti-VEGF, most common anti-VEGF what we use are ranibizumab, aflibercept, and now we have also received FDA approval for brolucizumab as well for diabetic macular edema. The other one being steroids, dexamethasone implant, triamcinolone, and there is one more implant, fluocinolone, which is not available in India. And the other one, gold standard, is the laser photocoagulation, and the last resort for us remains the surgery. So let us start with some real world scenarios. So we are a part of a research team, and Dr. Aditya Sudhalkar has done a lot of research on the dexamethasone implant, and he has concluded with the other colleagues that dexamethasone implant remains a very, very valid option in treating diabetic macular edema along with cataract surgery in treatment naive eyes. So let us start with the clinical cases. So here is a patient who has a 660 vision and a decent cataract with a diabetic macular edema. You can see a very big cystic space and lots of hard exudates around the fovea. So this patient underwent a cataract surgery along with the dexamethasone implant, and at the end of 3 months, he was very happy. We were very happy, as well as he was very happy to have a 612 visual acuity maintaining at the end of 3 months, and lot of decrease in the intraretinal fluid. He subsequently did receive some more injections because this diabetic macular edema is a recurrent condition, but he was doing very well at the end of 3 months. This is another case in which there is a massive diabetic macular edema and some RP layer disruption as well. So we were not expecting a very good result even after the treatment, but we were very happy to see that after the dexamethasone implant and the cataract surgery, patient received a very decent visual acuity improvement with almost near total complete resolution of the intraretinal fluid. So Dr. Aditya Sudhalkar has already described how we put a dexamethasone implant along with the cataract surgery, but this is just to show that first the cataract surgeon finishes the cataract surgery, and once the cataract surgery is over, an IOL implantation is done. Now it is the choice of the doctor if he wants to put a suture or what, and then gently we go tangential to the eye and make sure that it is facing the optic nerve, and make sure that implant is at least visible in the from the pupillary plane. So this is one more interesting case. This is a one-eyed patient. Right eye has an inoperable tractional retinal detachment, and the left eye has a diabetic macular edema along with the cataract surgery. So we went ahead with a dexamethasone implant and a cataract surgery, and the patient was doing quite well. We can see almost the complete resolution of intraretinal fluid, but there is little more. In this patient, we also saw that as he is one-eyed, we didn't want to give frequent injections. So we saw that there are hard exudates threatening the fovea, if you can see on your left sided image, and we decided to go for a focal laser photocoagulation in this patient after the cataract surgery, and this is after 1.5 months of the focal photocoagulation. We see lots of resolution of the hard exudates, and patient is doing very well without any injections. Like, he needs about 1 injection a year and he is absolutely fine. So this is a very interesting case. Once again, we did an OCT and we also did a retinal consultation and everything. So everything looked okay on table, and we felt that this patient does not have any diabetic retinopathy. So we went ahead with a normal cataract surgery. After the cataract surgery, he developed macular edema in the right eye. We were still in an impression that this is just a sort of Irwin gas, what we expect after the cataract surgery. But then something came into our mind, and we went ahead with a fundus fluorescent angiography. And while doing an angiography, we saw that this patient does have a moderate to severe type of diabetic macular edema in both the eyes, just not one eye. So we went ahead with the dexamethasone implant, and we received a near total resolution, and followed by that we also did a focal laser photocoagulation, and the patient is doing absolutely fine after 3 months. So this is another case in which we did not use. This is a proliferative diabetic retinopathy, and you can see on your right sided image that there is an active neovascularization. So this is a proliferative case with a PRP already done, but in spite of a PRP, the patient still has a neovascularization, what we can see in the red free image as well as the color images. So at this point of time, we went ahead with anti-VEGF instead of a dexamethasone implant, and he also had a macular edema, I forgot to say that, and after putting the anti-VEGF, we got the neovascularization went off, and after that we did some top up with the PRP and some focal laser, and the patient is doing absolutely fine. So this is one more patient with vitromacular traction. This patient is also a post pan-retinal photocoagulation, and usually the vitreous is very sticky in such patients. So just to show you how after the cataract surgery is done, we usually put a suture to secure the wound. We do a standard pars plana vitrectomy and stain the vitreous with the ILM, and after doing that, I'm sorry, I'm not able to fast forward my slides. Okay, so after that, we were very thrilled to see that we got a near total resolution of the vitreomacular traction and near total resolution of the diabetic macular edema and the VMT. So as the time does not permit, this was also one of the case with in which we put a dexamethasone implant but still had an epiretinal membrane. So while doing the cataract surgery, we did a cataract and we also did an ILM peeling after staining it with the brilliant blue. And this is what the post-operative appearance is. The patient regained a very good useful vision. And to take home message that systemic evaluation is extremely important for any diabetic macular edema patients. We need to make them realize what is really important and what is going on with their eyes, and a tailored approach is absolutely necessary. So it's not that one shoe fits all. We need to decide a customized approach for each and every patient, and that is how we treat diabetic macular edema and cataract. Thank you very much for your kind attention.
Thank you, Dr. Shamal, for highlighting that how we can use medical as well as surgical therapy on a case-to-case basis in treating cataract with diabetic retinopathy. I'm Dr. SHAIL VASAVADA. I'll be talking about certain principles that we find useful in treating a patient who presents to us with traumatic cataract. Most of these patients are typically young in age, like this one was a 17-year-old male with a history of a wire injury before 1 month. And as you can see, there is a white cataract that typically means that there has been some rupture in the anterior capsule, and you can see the entry wound along with synechia to the iris and some lens matter already present in the anterior chamber. It's important that if possible, we must re-evaluate these patients pre-operatively. Like in this case, we did the UBM and we found that the posterior capsule seems to be intact. So that's one good news before starting the surgery. But trauma can present as a Pandora's box in any situation. So first, what we would like to do is that this entire area is open. So we want to try and convert at least the rest of the part of the intact anterior capsule into some sort of a semblance of an anterior capsular axis to provide a strong margin. So we were able to do that and converted the broken edges from both sides. Most of these cataracts are typically soft and young patients, so therefore we most of the times do not require very high fluidic parameters. Like in this case, we are using an intraocular pressure of 20, and although we were sure that there is no posterior capsule defect, always maintain the principles of closed chamber technique. So now we have this situation where we have a half open bag. Posterior capsule is intact, but the anterior capsule, there's no anterior capsule on this side. The safest and simplest option is to go ahead and place an IOL in the bag. But like many of us have seen that over the years, particularly in areas with no anterior capsule, the optics sometimes tend to prolapse. There are chances of pupillary capture occurring, chronic inflammation, uveitis, so on and so forth. So therefore, what would be the ideal option, the type of IOL, so on and so forth. Having some experience of doing posterior optic capture in pediatric cataract as a general, we decided to apply that same principle here. So in an intact posterior capsule, what we are doing is we are creating an opening in the intact posterior capsule, and we are creating a central circular posterior capsulorhexis. And by doing, if you convert a posterior capsule tear, even if it's a PCR, into a posterior capsulorhexis, you have a very strong margin on which you can actually rest the intraocular lens as well if required. Having done the posterior capsulorhexis, we realized that the anterior capsulorhexis is also a little bit small. So making a nick with microincision rhexis forceps and converting or increasing the opening in the rest of the half of the anterior capsulorhexis, as well as now again re-enlarging the posterior capsulorhexis, because our aim, our primary plan is to do a optic capture. So here, this, as you can see, is the posterior capsulorhexis, and this is the half open bag on the anterior capsulorhexis side. So we went ahead and placed a 3-piece IOL because the capsule was open. Sometimes the injector systems can be a little bit troublesome. So we are going ahead with a holder folder injection of the IOL, and the IOL is placed with the haptics in the bag. And once that is done, I am pushing the optic through the posterior capsulorhexis behind the PCCC, which means that this IOL will now be locked in its place. So there is no possibility of this IOL moving. Perfect centration, and of course good clear visual access also, because they are most likely to develop VAO in such young guys. Always confirm when you open the capsule, posterior capsule, that there's been no vitreous disturbance, which fortunately in this case there wasn't, and this is how the patient looked at the end of surgery. So the principle of optic capture is to lock the lens in its position. So this is very important, particularly in such traumatic eyes. It gives great stability. This is an experiment done by my colleague Dr. Samresh to show that if you have a half open bag, you have possibility of the IOL moving and shifting in the eye. Compare that to the optic capture where it's actually locked. Nothing is going, this IOL is not going to move no matter whatever happens to this eye. And this is that same patient doing well post-operatively. As you can see, this dumbbell sign is typical of a posterior capsule rupture. This is the anterior capsulorhexis open on one side. And what it also, the other advantage of an optic capture is that because it's the anterior and the posterior capsular leaflets fuse together, lens epithelial cells migration doesn't occur, and therefore even visual access remains clear. Another patient, 16-year-old, injury with a firecracker 2 weeks earlier, and once again you can see there's a synechia and a split in the anterior capsule with a white cataract along with pupillary distortion. This pupil is now fixed in this position. Again, once the lens removal was done, fortunately the posterior capsule was intact, and we are going ahead by creating an opening in the posterior capsule and using micro incision rhexis forceps and going from one side port to the other. And these are the eyes where you do need a good cohesive viscoelastic. Helon GV is our preference in such eyes. And slowly but surely we are able to create this into a reasonably large posterior capsulorhexis, and we went ahead with an optic capture of the 3-piece IOL. And because the pupil was also distorted, we had to do something about it. So here we are doing the single pass 4th row pupilloplasty described by Dr. Amar Agrawal and Dr. Priya Narang. And in the end, of course, always make sure that there is no vitreous disturbance that has occurred, and this is how the patient looks now 2 years post-operatively. So I think this is one option to keep in mind as far as treating traumatic cataracts are concerned, so that even if you have an intact posterior capsule, you can create an opening in it and make sure that the IOL remains locked and stable for better long-term outcomes of this eye. Because if the IOL stays away from the uvea as much as possible, better it would be. Thank you so much for the patient listening. And now it's my pleasure and honor to invite one of the most renowned ophthalmologists globally, Dr. Rajesh Fogla sir, who will be talking to us on how to approach a patient who has Fuchs dystrophy and cataract.
Thank you, SHAIL. Good morning, everybody. It's always been a privilege being part of your course. And this is quite an important topic. I have no financial interest in this subject. Fuchs dystrophy is not uncommon. You do see in your clinical practice. And it's important that besides looking at the cataract, which is the most obvious finding, you do look at the cornea, especially the posterior aspect of the cornea, and see whether you can identify that orange peel kind of appearance. Fuchs dystrophy typically occurs in the age group 55 to 65 years, and it does have a family history as well. You can see on anterior segment OCT an increased thickening of the Decimus membrane, and also the overall thickness of the cornea increases. And if you do a specular microscopy, you will see those dark spots. Patients can have symptoms of glare, decreased contrast, blurred vision because of Fuchs dystrophy, but these are symptoms which are similar to what you get with cataract as well. But if your patient typically says that when I get up in the morning, my vision is blurred and it gets better during the course of the day, keep a watch for, whether the patient has a Fuchs dystrophy. Corneal tomography can help identify early Fuchs dystrophy, not only by looking at the increased thickness, but also if you look at the posterior elevation map, you will see a posterior depression, which is again because of when the cornea starts becoming edematous, it affects the posterior corneal curvature much before it starts showing up the microcystic edema. The cataract management, you can have loss of up to 8 to 10% of endothelial cells, and this is dependent on the cataract density, the anterior chamber depth, and the pupil dilatation. And a study where they looked at a cutoff value of 640 microns and they performed cataract surgery, the corneas which had a thickness of more than 640 microns, almost 22% ended up with keratoplasty. So the advantage of doing a cataract surgery alone in the presence of endothelial disease is that you can avoid all the complications which are associated with corneal transplantation. You don't need to put the patient on steroids for long term, thereby avoiding glaucoma, the risk of rejection, and you don't need to see them too frequently. But as it's a progressive disease like the Fuchs dystrophy, you will have visual deterioration over a period of time. What kind of surgical technique you will perform? Ideally, most of us do perform the phacoemulsification, but if the cataract is very hard and if you're not confident with that, I think a manual small incision cataract surgery or an extracapsular cataract surgery sometimes works better in this scenario. In very eyes which have shallow anterior chamber, and this we have learned from our Japanese colleagues, that you can perform a limited anterior vitrectomy, which can help increase the space in the anterior chamber and thereby make it safer for the cataract surgery and reduce the risk of damaging the endothelium. If you know that you're going to go in for an endothelial keratoplasty, always aim for a little bit more myopic than minus 0.5. I would say that you aim for -1 or minus 1.5. Don't choose a hydrophilic IOL, because when you do a endothelial keratoplasty and you use air or gas tamponade, the reports of opacification of hydrophilic IOLs have been reported. So use the hydrophobic IOL, use a monofocal lens. A multifocal may not be the best because you may not be very accurate with your IOL power calculation. I would prefer an extended depth of focus lens. And during surgery, yes, the decimus membrane attachment is not very firm. So use sharp knife, use dual OVD using the soft shell technique, use the BSS plus, and avoid any kind of intracameral medications, because the endothelium is already not very healthy. And if you put any kind of intracameral, antibiotics or dilating drops or anesthetics, they can be detrimental to the health of the endothelium. Don't try to be too aggressive with your wound hydration, because here the attachment of the DM is not very firm and you may induce a DM detachment in that scenario. If you do have a leaky wound, I think I would prefer to just place a suture rather than hydrating the wound. And near the wound, you may have a greater tendency of having a small DM detachment. So at the end of surgery, putting in a small air bubble in the anterior chamber is always helpful. So if you have anywhere small DM detachment, this air bubble can help secure that back in place. You may need to use steroids with greater frequency, because these are patients on day one post-op. They may have some corneal edema. So plan and tell them preoperatively that your vision on day one may not be very clear. You may need to use some, medications for a longer period of time. Use topical hyperosmotics. Monitor the IOP, because raised IOP also reduces the function of the endothelial cells. Watch out for DM detachment. If there is edema, do an anterior segment OCT, because on slit lamp examination, sometimes you may not pick up those shallow detachments, whereas on OCT you can pick up. And the corneal edema, usually before you jump in and recommend endothelial, because I get patients referred 2 weeks, 3 weeks after cataract surgery with diffuse edema, saying that he's not getting better, do an endothelial keratoplasty. But unless you have remove the DM, then it's fine. Then there's no point in waiting. But otherwise, I think 8 to 12 weeks is a usual time where before we go ahead and plan for any kind of endothelial replacement surgery. Well, there is increased risk of endothelial failure if there is already pre-existing epithelial edema, or you see presence of folds in the posterior cornea, or if you start seeing subepithelial fibrosis, or the guttae, instead of being limited to the center, you find that these are extending all the way to the periphery. Then you know that this is a more advanced form of endothelial dystrophy. So basically, you can use both the pachymetry and the cell count as the markers. I would say that if somebody has a thickness of more than 650 and cell counts of less than 800, maybe going ahead and doing a combined surgery makes more sense. But if the pachymetry is less than 650 and you find that the cell counts are maybe 1,000 or more, you can still go ahead, and the cataract is not very hard and you can do a comfortable surgery. You can always do a sequential surgery where you do the cataract surgery first and come back and do a corneal surgery later. If the guttae are limited only to the central 4 millimeter, 5 millimeter area, because in a young patient that can be, you can think about doing a isolated stripping of the decimus membrane only in the central area, and then post-operatively you treat with steroids and rho kinase inhibitors like ripasidil or netarsidil, and you find the peripheral endothelial cells over a period of 1 to 3 months can migrate to the central cornea and clear the corneal edema. The only disadvantage is that the moment you do the procedure, the very next day the patient will have a dense central corneal edema, which will take 1 to 3 months to resolve. So you need to counsel the patient for that. In our kind of clinical practice, because we don't operate on like patients with 6669, we don't see those patients. But in the West, they have been doing that and they have been successfully able to manage that. But this doesn't solve the problem long term, because down the lane, several years later, they will still have progression of the guttae and they will require endothelial keratoplasty. So you can see that, so you can have pre-operatively a lot of guttae or you can have the post-op. So in this kind of scenario, you can do the endothelial keratoplasty, whether you do a DSEC, ultra-thin DSEC, or the DMEC. DMEC is now traditionally the preferred technique in this scenario because it gives better refractive outcomes and faster visual recovery, and it has the lowest risk of rejection, and it can be combined with cataract surgery to give more predictable refractive outcomes. Studies have looked at performing a combined surgery, and they found that combining the two procedures does not increase the risk of postoperative complications. We can do surgery sequentially very fast. Like I did one eye, a phaco-DMEC, and within a week I was able to go back and do the fellow eye phaco-DMEC as well, because the first eye had recovered. And it just happened that we had a pair of tissues, so I used the same pair of tissues. It was kept in Optisol, so 1 week later I went and did the other eye as well. And even this is a patient who had a non-resolving edema following cataract surgery. So here also you go ahead and do a DMEC, and you can see that the eye looks pretty much like if somebody examines the eye, they won't be able to figure out that endothelial keratoplasty has been done. Even in phakic eyes with DMEC can be done initially, because this is a young patient, 40-year-old with Fuchs dystrophy. So we went ahead, did the DMEC first, and later on now if she develops a cataract, you have a better chance of choosing an IOL, whatever IOL, whether you want to put a toric IOL or even if you want to put a multifocal in this scenario, you can do. So there are some surgeons in the West who prefer to do a sequential surgery. They do an endothelial keratoplasty first because they can do a better IOL power calculation when performing later. And you do get a little bit of hyperopic shift with DMEC as well, and that's something to do with the rate of clearing of corneal edema. The central edema clears faster, which makes the posterior curvature more myopic. That's why you get a hyperopic shift. When the peripheral edema resolves, this hyperopic shift disappears. This is a study where they did phakic DMEC, and later on when patients developed cataract, they went ahead, did a cataract surgery, and they did find that the endothelial cell loss from the cataract surgery was not very significant, and the majority of the eyes achieved 20/30 or better, and the target refraction was within plus minus 0.5. So, well, if you have Fuchs dystrophy with lens changes, you can plan for cataract surgery alone and plan for endothelial keratoplasty later. If the guttae are limited to the central cornea, you may just do a decimal stripping only, or you can combine the two procedure. Or if it's a younger patient, cataract is not significant, you can think about doing a DMEC. So this is a flowchart that kind of covers whatever we have spoken about now. So you have newer diagnostic methods to quantify the corneal changes in Fuchs dystrophy. The choice of procedure also depends on the patient's expectations. Somebody does not want multiple surgeries, you can do a combined procedure. Or if somebody wants perfect refractive outcome, wants to go in for multifocal, maybe you can do a endothelial keratoplasty first, and 3 to 6 months later, you can go ahead and do a premium IOL surgery. And in future, we may have cell-based therapy where you don't even need to put in a cornea transplant. You may be able to inject cells just like you inject your anti-VEGF at the end of surgery. You just inject cells into the anterior chamber, patient lies face down, and the endothelial problem is resolved. Thank you for your patient hearing.
Thank you, sir, for that excellent overview. Sir, I had one question that if we find clinically that let's just first go for cataract surgery and later if it decompensates, we'll do the DMEC, DSEC. In such eyes, would you start them post-operatively or starting pre-operatively on Rho kinase inhibitors? Or
Well, it's not very clear what exactly Rho kinase does. So from the understanding what we have from, see, all these Rho kinase inhibitors currently which are approved for management of glaucoma, and what they have seen with decimal stripping only is that it increases the mobilization of cells from the periphery to the denuded area. People have used it, but if there is presence of any kind of epithelial edema and you use the Rho kinase, it actually makes it worse.
Okay.
But yes, in combination with steroids, if you want to use Rho kinase inhibitors to kind of allow the peripheral cells to start migrating to the center, it can be done. So we don't have an exact answer, but yes,
correct.
Post-operative, it's an option. But I have also seen patients after cataract surgery, when they are started on Rho kinase, they come to me faster for endothelial keratoplasty because they become visually more symptomatic.
Correct. Absolutely, sir. Wonderful, sir. If there are any questions from the audience,
I have a question, sir.
Sure.
Post DMEC, when you in phakic DMECs, when you go in for the cataract surgery, what is the soonest that you can go, and what is and do you have a backup DMEC tissue ready in case it moves?
The graft is not going to separate on its own. It's quite firm. So you don't have to worry about that. But yes, you would do a specular count before you embark on your cataract surgery and see what kind of cell counts you have, look at the corneal thickness, and do have a word with the patient and tell them that, in the worst possible scenario, if your cornea doesn't clear after the cataract surgery, we may have to replace the DMEC donor. But so far, the cataract surgeries I have performed after DMEC, we have not had a significant amount of endothelial change. Because our surgeries, the cataracts are not very hard. It's more of the posterior subcapsular cataract, and you're able to manage them pretty well. But yes, the earliest I would recommend is maybe in a month's time is when you can do that. But ideally, you would wait for topographic stability to allow you better IOL power calculation. So at least 3 to 4 months.
And would you change your viscoelastic for the cataract surgery?
I would still use the same, both a dispersive and a cohesive, just like you do for compromised endothelium.
Thank you.
Thank you very much to the audience.
Yes. So as I said, keratometry is the most important measurement for a good biometry. When you do the keratometry, you have to also find out whether it's a regular astigmatism or an irregular. For that, you will need to do an additional, at least an additional investigation of a topography. So if the pterygium is inducing irregular astigmatism, we wouldn't go ahead with a toric IOL or even a aspheric. Probably a spherical would be a better outcome. Because if it is an irregular astigmatism, if you're leaving behind any refractive error, a spherical IOL tolerates that refractive error much better than an aspheric IOL.
So I think we'll take the question downstairs because we have to clear the podium for the next session. Thank you so much once again.